वगैरह कुछ डालना
वो
होता
चेंज
है?
कर दिया मैंने। अभी यही वाला है ना सबलक्सेशन वाला।
प्रेजेंट ये वाली प्रेजेंटेशन।
हाँ ये वाला। तो अगर उनको मतलब अभी सपोज ये चलाएंगे प्रेजेंटेशन तो वो खुद भी दिखेंगे और प्रेजेंटेशन भी दिखेंगे, दोनों दिखेंगे। ठीक है, थैंक यू। तो हमसे प्रश्न पूछेंगे
और किससे पूछेंगे, अभी तो बैठे हैं सामने। ये आज
आप उधर बैठो, मैं वहाँ जाकर बैठ रही हूँ।
मैं पीछे बैठते इकट्ठे बैठे एक एक सीट छोड़ के। गर्मी है, कुछ चलेगा कि नहीं?
हाँ इसी वजह से कुछ चलेगा, वहाँ चला देते हैं।
ये बस यही नहीं, क्वेश्चंस कैसे पूछने हैं, उनके सर आप पूछना फिर वो रिप्लाई कर देंगे। अच्छा आई वांट पीपल टू सी देम, उनको नो सेंस है कि हम ही बैठे होंगे सामने।
Okay, let's check it out. Okay, good evening, students. But I don't see any students here, so of course, I think you can see me rather than me seeing you. It's okay. So when the times change, we have to change our techniques. So today I'll be talking about the subluxation of the lenses. Now, you working in the tertiary hospital, I think you better get used to operating these lenses because most of the people in practice might not touch it and they'll be sent down your throat. So what exactly is subluxation of the lens? Subluxation means that there's a lack of the zonular support. There could be broken zonule or stretched zonules. Now what are zonules? Zonules are nothing, basically they are vitreous only. They are tertiary vitreous. So you can say it's a vitreous support which could be in the form of the hyaloid from the back or as a tertiary zonules, which is the tertiary vitreous, which is the zonules. So you can have a subluxation or you can have a dislocation. When you have a total loss of the grip onto the vitreous, that is, it is not sitting on the patellar fossa. There's a fossa at the back, which basically the imaginary fossa. So it's basically a condensation of the vitreous in the front, just behind the lens, and on which the lens sits. So once lens is displaced from there anteriorly, or it goes all the way off the patellar fossa, it's called the dislocation. And if part of the lens, which is right now as it's visible here in this slide, first one, this is called a subluxation. Okay. So the etiology of the subluxation could be, is the volume okay? Low. So I'll get close to the mic. I'll get closer to the mic. I'll pull it up. Mic आगे ले लेते हैं. Is it better now? Yeah. Okay. So the etiology depends on few things. I think you're checking. Okay, it's good now. So basically, etiology can be divided into three groups. It could be traumatic or spontaneous or hereditary. For the kids who are preparing for the exams, it's easier to remember if you can remember TSH. T is a traumatic, S is a spontaneous, and H is a hereditary. Now, what do you mean by spontaneous? These are the one in which, for example, if a high myope patient is there, the zonules might get stretched and the lens might get subluxated or dislocated. So those are spontaneous ones. And pseudoexfoliation patients, post-trabeclectomy surgeries, or if you've done a DLCP or cyclocryo in these patients, the zonules can become weaker and the lens will not stay in the center. So those are spontaneous ones. The traumatic ones, everybody knows the closed globe injury is the commoner one, then the open globe injury. And you have the hereditary ones, which commonly are Marfan's, homocystinuria, microspherophakia, but Marfan being the commonest in this group. So the traumatic ones will always have a history of injury, especially. Injury has to be significant, otherwise the lens is not going to get dislocated until unless the patient has already undergone maybe a vitrectomy surgery, or the zonules are weak, already high myope. In those ones, even a little amount of trauma can cause subluxation. But in majority of the patients, especially in the youngsters, the vitreous, in which the vitreous is well formed, the injury has to be quite severe to cause a dislocation. So the subluxation or dislocation happening, there is always associated angular recession, or there could be sphincteric tears, there could be hyphema in the anterior chamber, and there could be vitreous herniation from the anterior into the anterior chamber. In all these patients, once these anterior segment signs settles down, you always look out for the vitreous hemorrhage at the back, detachment, or the Burley's edema. There you could always get you may get a choroidal tear in these patients. And the closed globe injury are more common to cause subluxation. Now, these are a few examples. If you can see, this is the eye with hyphema in there, and you have seen the sphincteric tears in this patient, and this one in which there's a herniation of the vitreous coming from the side. Okay. Now, second group is a congenital one or a hereditary one. In this, the biggest advantage you have is it's a soft cataract, and these are picked up early in the age, and vitreous is firmly supporting from the back, so it becomes easier for us to operate. And usually they have a mild to moderate subluxation, not too severe a subluxation. But patients like a spherophakia will have a total subluxation and could be a total luxation. There could be a myopia and astigmatism. Once the lens becomes globular, it tends to change the refractive index of the eye. Even if the lens is clear, it can cause myopia maybe up to -16, 18, maybe sometimes up to -20. And this is usually picked up in school age growing group, because if the kids are inside the house, they know the surroundings well, and the distance where they focus is not too far away. So most of these kids will come to us only once they start going to school, when suddenly the distance from the blackboard and the stool where they sit increases. and they are not able to cope up. And the parents, the teachers will tell the parents, and eventually they'll come back to us. And they usually associate with the cardiac and skeletal anomalies. Now, if you talk about Marfan syndrome, the earlier teaching was that you have to see all the span with the height and wrist sign, thumb sign, and hereditary, everything, all things were important. But they're not important anymore, because if you follow the Gantz criteria, according to that, if you have a subluxation and you have an echo-proven cardiac lesion, you have to be, it has to be proven on an echo, not on just examination. So once these things comes together, it becomes positive for the Marfan's. And these are the patients which, if you don't operate earlier, can go into can go into amblyopia, dense amblyopia actually. So they can present in any way. It can go upward dislocation, it could dislocate downwards, it can come anterior, or it can come all the way anterior. This slide, if you see, the lens is actually sitting behind the endothelium. It's on the surface of the iris, and I'll show you the surgery of this patient later on. Okay, and it could have lots of cataract. And this, the nucleus close is about 3 to going to 4, and there's a vitreous which is herniating. So you have to decide which are the patient you want to operate, and which are the patient in which you want to fix up the bag, which are the patient in which you want to leave them aphakic. So the signs before you take them up on a clinical slit lamp examination, you can pick up a pre-operative phacodonosis or iridodonosis. So basically, because of the lack of the support from the zonules, the bag will move, and because the lens has gone backwards, the iris also starts moving. So the phacodonosis and the iridodonosis are seen in these patients. In some patients, they are grossly big, huge donuses, but in most of them, you might see a subtle change. So you have to be very careful about those. Once you see a presence of the vitreous coming from the side of the lens, so that is a short sign that there's a breach in the zonule somewhere, and the vitreous has come anterior. If the chamber goes anterior, that's a gross sign of a dislocation. The half the lens has gone down, and there could be exfoliation or the pigmentation of the surface of the lens, which will eventually lead on to tell you that it's a subluxated. On the table, most of the time you'll be able to pick up pre-op, and sometimes on the table, the moment you try puncturing the anterior capsule for the rhexis, that's the first step you do. The moment you puncture it, you feel it's like a flaccid balloon. It's not a firm balloon. So it's a flaccid balloon. You push it down, it gets pushed backwards. It doesn't get ruptured. And once you've done that, you realize that the rhexis is not running in the proper way where you want it to run. And there's an anterior capsule which is extra in these patients. So for example, you feel that there's a wrinkling of the anterior capsule in these patients. And when you start doing the rotation, it's very difficult to rotate. The entire lens rotates rather than the nucleus. And there could be a sudden posterior dislocation of the lens the moment you start doing a hydro in these patients. You haven't realized anything, you've just done rhexis, and the moment you start doing hydro, you suddenly realize that whatever zonule support or vitreous which was supporting at the edge has given way, and the lens falls backwards. And there could be a vitreous herniation seen on the table, and that can be picked up very easily the moment you put in the air bubble to put a dye on the capsule. You realize that the bubble is not round, it's getting pushed because of vitreous which is present somewhere in the corner. So the surgical approach to these patients will depend on 4 things. One is the amount of the luxation, depending is a subluxation or a dislocation, and how many clock hours it has gone off. The presence of the cataract. The cataract is soft versus a cataract which is well formed in a hard cataract, your approach will change. The vitreous status. If the vitreous is liquid in a case of a myopia versus a liquid vitreous which is firm, especially in a case of congenital cataract. So your approach will change, and I'll cover up all these points when I'm showing you the videos. You can always do a UBM in this patient, and you can be wiser, because in a case of subluxation or you will find, especially in a Marfan's case, on a different days when you do a UBM, you'll find sometimes the lens is in the posterior.
So when we know just false के लिए बोल रही हूँ, we are checking the volume.
Okay, I think they're checking the volume. Just hold on for a minute. Should be okay.
Yes, sir. Right. Okay.
मैं कर लूँगा उसको. Is it okay now, the volume? Okay, so I'll reach up where there. Let me. So the surgery will depend on these 4 things which I just told you. So let's see how it's going to make a difference. Now, if you see the slide number 1 on this side, this lens is totally gone. So there's no way that you can bring this bag into the center, put iris hooks and do the surgery and fix the bag. This will be almost impossible. So here you can eat up the bag, do a lensectomy, and you can have options which I'll be telling you later. So, and this is the one in which you still can put iris hooks and put a bag, do a rhexis, and go ahead with the surgery. Similarly, minimal cataract, it will be easier to perform versus a cataract, which is quite a hard cataract in this patient, and the lens is subluxated. So if the luxation is more, then there are not too many options. Either you leave a patient aphakic. We still leave some patients aphakic in which we can't do anything. But in majority of these cases now, we do a lensectomy, vitrectomy, and we can put an AC lens. We just finished a thesis on AC lens, which has been published. The problem of the AC lens, we'll be talking about that. The other set of AC lenses which have started long back, about 40 years back, and they come back in vogue again, are the iris fixated lenses. Rather than putting them in the front of the iris, we put them behind the iris. I'll show you certain videos and tell you how to do them properly. Then scleral fixated lenses is another option, glued or not glued, and eventually if you can't do anything, you can leave them aphakic. If you're leaving the bilateral aphakic, you can use aphakic glasses, and if it's a unilateral subluxation, you'll have to use contact lens in the patient, in which you can't do any of these procedures. Okay, so the bag fixation devices are basically useful when they are less than 4 Khokhar. Is you can use a capsule tension ring. It's like a small ring with something like a hanger you use to put your coat or a shirt in your almirah, and you can use a capsule tension segment which is small, and this one is capsule tension ring. So I'll just give you the example of these one with the video along, and the ones in which there are more luxation, maybe 4 to 9 Khokhar. Here, just putting the lens into the bag with the CTR alone is not going to be the answer, because eventually these lenses will fall back into the vitreous. So you need to suture this bag lens, entire bag lens to the sclera. So you need modified sionis, and modified sionis have a knuckle in which you can pass a suture and you can suture it to the sclera. Okay. During the surgery, you need a support so that the bag doesn't move. These are the mobile bags. So you can use CTR if it's the smaller, like subluxation, maybe less than 2-3 Khokhars. If it's more than that, you have to put iris hooks. You can put iris hooks about 4 to 6 depending on the subluxation, and then you can do the surgery. And at the end of the surgery, if the luxation is more, you have to suture it to the sclera for lifelong. And this is an important thing, because if you don't do that, the bag is going to fall back. Bag taking all the sioni, CTR, everything will fall into the vitreous. Okay, so these general points I'll tell you during this surgery only. So now, how does the CTR work actually? CTR basically works by, it basically does 3 things. It redistributes the tension from the existing zonules. So all the zonules which are intact will give strength to this. They'll support the CTR, and CTR will support the area which is subluxated. It will recenter the mildly subluxated bag. If the bag is a little mildly subluxated, you put in a CTR and it gets centered. And the third is expansion. Whenever there's a subluxation, the lens will start losing its diameter, across diameter, and the AP diameter starts increasing. So the moment you put in the CTR, it expands it equatorially. So thus the AP diameter reduces in these patients. Okay. And timing of the CTR, I'll come to that. First, I'll just show you how it's done, and then we can come back. Okay. So now if you notice this video, now this is the rhexis which are done, and it is not in the center. You see it's off the center. So it's mildly off the center. So let's see what happens if I push this CTR in, what happens to this subluxation. So CTR is going in, and this is a 11-13, it's an adult patient. In the kids we use 10-12, in the adults we use 11-13. So see, the moment this has gone in, this rhexis has come into the center. Okay, so that's the trick. Now, if you don't have a rhexis intact, putting a CTR inside might cause more hazard. It can increase the nick in the rhexis. So once this happens, you see the vitreous has gone backwards, and this vitreous, which is fluid, and this is behind the capsule, not in the front. And if it's in the front of the capsule, you can always do a vitrectomy after constricting the pupil. You can put pilocarpine, and if it constricts on the top of that, you don't have to do anything. And if it doesn't constrict and has it doesn't allow the pupil to constrict, you can do a mild little vitrectomy, just localized to this area, and you can get away. At this stage, it was put after everything has been done. Phaco, aspiration, everything was done. So this was not too big the subluxation. Okay. So now, when can you put the CTR? CTR is an appliance which you can put any time of the surgery, but after the rhexis. So you do a rhexis and you put it inside. If it's a mild subluxation, you put in the CTR, it will cause the expansion and it increases the strength of the zonules, which are from the intact zonule to the non-intact zonules, and it will help you in phacoemulsification also. But if you have a very hard cataract, say 3, 4, 5 grade, and you put in the CTR before, then the entire complex of the bag becomes more dicey and it might fall down. You can in fact have a iatrogenic zonal dialysis, so it should not be done. The only problem is sometimes the cortex gets stuck in that one. So it's something like removing the towel. So if you hold the towel from both the ends, from the anterior posterior both, and pull it, you won't be able to take it out. So you have to ensure that you use one edge, either anterior or the posterior of the cortex, then only you can pull it out. Otherwise, the moment you pull it, the CTR will start getting inside and it can cause more damage. Okay. So after the phaco and cortical removal, you have used iris hooks during the surgery, and once you remove it, the risk of dislodgement of the iris hooks are there, so that has to be taken care. And once you remove the hook, if the hook is sharp, it can cause tear. And how to avoid this will come in the subsequent videos, please. So this is what I've just showed you. And there's a technique in which for the beginners, if you're trying to put in your CTR and you just lose it, it might go over top of the iris and you can't see it. For example, in this patient, I'm putting the leading edge, the cortex is still there. I'm putting the CTR in, capsule tension ring in, and there's a suture which is on the trailing eyelet. So it's gone in, out. So I pulled it out again, use a Sinski, and once it goes into the bag, now I'm sure it's gone into the bag. I cut the suture from outside and pull it out. So basically, for the first few patients, if you do this, even if you lose it, you're not going to cause much complication. Otherwise, if it goes on the top of the bag, it can sometimes increase the zonal dialysis and break more zonule, and that becomes counterproductive. Okay, the trick is, if you're using a Sinski for the hole, please use a thinner Sinski. Sometimes we have thick Sinskis, it goes and gets stuck into the opening. It gets stuck in the eyelet, and you want to push it out, and that way you can cause more complications. Please always make sure there's a thin, very small tip Sinski which can be used for this one, and you can grind it off. It's a thick one and use it for this purpose only. And in the severe dislocation, it can fall into the vitreous also. So be careful about that. Now that is what I was telling, in which you don't fixate the bag. You just support the bag and you change the AP diameter so that lens becomes stable and the power is given from the zonules, intact zonule to the broken zonules. Now this is the one in which you see there are extra eyelets here. So these eyelets are needed for putting the suture through it onto the sclera, and you can put it to the sclera and use a non-absorbable suture. So this is going to stay there for lifelong and keep the bag in the center of the eye. Okay, so the capsule Sioni rings have limitations, because if the size of the bag is small, there are not too many sizes of the Sioni rings available. In CTR you have 2 sizes, in Sioni I think you have just 1 size available. And you have to have a rhexis which is a decent size. If it's too small a rhexis, any rhexis which is less than 4 millimeter, a capsule rhexis will not work very well. So small decentered rhexis is a contraindication for this one. And if you have a small rhexis, please enlarge it to some extent before you put in your Sioni. Whereas the CTR can go in that, still it can go in. Alright, when you're passing the sutures, make sure they don't take a corneal bite. I've seen people struggling. They put in everything and there's a cornea bite which has come along and you don't know what to do. If you want to cut the corneal tissue, then if the suture gets cut, everything has to be done again. And it needs to be sutured to the sclera. So where you suture it's 50% of the flap thickness, which I'll show you in the video. Mark the center before you start mark the area where the maximum subluxation is there. I think I'll show you in the video only. Now, if you're suturing the iris, it's 1.5 millimeter from the limbus. This is a ubium. We done about 100 patients, and we realized that when we put it 2.5 from the limbus, we always have a better alignment of the bag. And if you make it anterior, this will be tenting anteriorly. So if you're suturing the bag, which I'm talking about right now, subluxation, you should be 2.5 millimeter from the sclera, from the limbal junction. So you can mark it before actually start the surgery. Okay, so I think I'll come to the video. And okay, now, so you need a beveled needle 26G, and you need a 90 Prolene. Why 90 and 26G? Because they match the best. Because if you see the opening here, it is very good for a 90 Prolene. If you use a 10 Prolene on a 26G, it's going to be slipping out again and again. and you can always check it out late before actually going into the eye. And how do you ensure 2.5? You put a mark at 2.5 and make sure that your proline, the 26G needle comes from that point inwards. If I try to put this long proline needle all the way from across, it will not, I can't ensure that it comes at 2.5 out. So one needle comes from 2.5 from out to in, and the other one comes from the opposite side. That way I ensure that it comes out at 2.5. Okay. So this is what a video is going to show you. This is what. All right. So I think if you see this video, that should sum up most of the things. So before opening up the conjunctiva, I had marked this one here because that's the area of the maximum subluxation. And then I make a scleral flap. You can use a blade breaker or you can use a crescent blade. Crescent blade actually makes your life much comfortable. So once you've got, it's about a 50% depth. Don't be too superficial, otherwise the suture proline will come out. Now you see I've given a nick and I'm doing the rexus towards the broken zonules. The trick is always give a nick and push it towards the broken zonule. And then I enlarged it and I'm using a rexus forceps. With the rexus forceps, you can change the direction of your force, pull and push much better than a cystitome alone. Now see, the lens is subluxated and I've gone more under the iris superiorly, and that's about a 4.5 to 5 millimeter rexus. The hydro has to be done very gently. Very gently hydro, just go with the small unims of the fluid under the anterior capsule. And here I've taken this nucleus out. This was not too hard a cataract, so I've taken the nucleus. I held it with my suction. You saw it going all the way up and I held it and brought it anterior. I chop it, and of course you use a viscoat in front of that so you don't have any damage to the endothelium. Go slow. And you can see this was done on an infinity machine. This is quite an old video. And you realize I didn't put any iris hooks because there was not too much of movement of the bag, and I could take the nucleus out. So once the nucleus is out, my fluid actually is not going into the bag. I'm into the anterior chamber. I'm supraciliary and supracapsular. Okay, then I go with the bimanuals. The bimanuals is a way to go in these patients. Now, the important thing is, because if you have bimanuals, you can control your force inside the eye well, and you can. Now, this is what is a Sioni looks like. You have a ring, which will do the work of the capsule tension ring, CTR, and the Sioni knuckle. So you see, I've used a 26G needle. I got it 2.5 millimeter from the back, and the moment I come here, I put in a blob of Helon GV under the iris over the capsule. You're not supposed to damage the capsule. You have to slide your needle over the thing, and you see I had a golden handshake, and one needle has gone, one part of the suture is gone. Then I pass it through the knuckle, and the second one I'm doing the same way. Make sure that you go into the incision, not take any bite here, otherwise you'll get stuck. You'll have to cut the cornea then. A little bit of cornea, you have to come back again. Okay, now once the sutures are gone, I'm putting this suture in. The trick is to put this knuckle under the suture, never be over the suture. If you see both the sutures, you can see here, that's why I stopped it. It has to be under the suture. If you both sutures are in front, you pull it from the other side, it'll go. But if one is under or both are under, you will always get in trouble. They'll all get locked up. So it's put like a ring, so it's going like a ring. Let it go. Your incision has to be about 2.2 to 2.8, otherwise this knuckle might not go in and it might get stuck. And if you try to fool around too much with the knuckle, it breaks. It's a PMA material. It's a very delicate material. And once it goes in, now the trick here is to have this knuckle over the capsule. Then only you can pull it out. So it should not be under it. If it's in the bag, it's not going to solve the purpose. So once it's over, you can tighten the first knot a little loose, and once you see it's properly centered, then you can tie it up and finish it off. So the bag is centered now. This was a lens which would have 4 to 6 clock hours subluxation and had a fairly hard cataract, about 2 to 3, and has been managed properly. So once the proline has been sutured, the other trick is when you've done a proline suture, please mark it on the card of the patient. Please do not do any suture removal. Even if they have irritation or something, some doctor outside might see a suture end coming out. He might cut the suture. It'll be a disaster because then everything has to be done back again. So please make sure that you don't cut the suture, and you have to make sure that you put 3, 4, 5 throws in this one. And second throw you can do the tightening, and the rest one are to support that knot, previous knot. And once that's done, you can put in the lens. If you notice the one thing, the capsule is not circular. It will never be circular with the capsular Sioni. So it will always be pulled up. So What happens because of that is that your chances of VO is pretty high in these ones. So that's what it looks like. Okay, now I was putting the needle from the distal end where the luxation was there. So you always put a pilocarpine at this stage and see if the pupil constrict well, that tells you that there's no vitreous coming from there. So because sometimes the vitreous is so clear that the needle passes through it and it drags it actually. It drags it towards the center. So in those cases you can do a vitrectomy localized there, or you can use a kinocot and it will become more visible and you cut it. And always use pilocarpine in these patients, and that's what it should look like at the end of the surgery. Okay. Alright. So why 9-0, why not 10-0? Because people in the past have used 10-0. There's a study which has come by Berkeley et al. Just tell me when the time is, 15 minutes left. So Berkeley et al. Found that 40% of the patients with a 10-0 proline opened up. They were not supposed to be biodegradable, but they do get degraded. So what they say that you should, Buckley study, I think everybody should read this paper. They said that 9-0 proline has advantage. It's 60% extra tensile strength, 50% extra diameter. So 9-0 to 10-0, the diameter goes 50% more, and it's 125% greater cross-sectional area, which is covering. So it works well with 26G, goes well, and so we, in most of these patients, we're using 9-0, we're not using 10-0 at all now for back fixation. All right, so CTR, when should you, when should you put it? Can you put it before? If you put it before, the problem is that you're doing phacoemulsification with the knuckle, with the suture, so you're going to get in trouble. So it has to be done only after phaco has been completed, and the phaco can be completed with use of iris hooks, which you can use on the capsule, and do the phaco. You can use put 3, 4, 5, 6, whatever fancies you. And once you finish the phaco, then you can actually take up the fixation to the sclera. Now, according to this study, which was done by Soon Fik, she's from Singapore, she found that you can put the lens before and then center it. I do it, I'd center the bag and put the lens later on. I mean, it doesn't make much difference, but that's what they suggest. In the long term, what can happen? If you saw, I was pulling the iris and I was pulling the the knuckle anteriorly. If the knuckle is too anterior, I'm not 2.5, I have 1.5 millimeter. So it will perpetually keep rubbing against the back of the iris. Every time the pupil constricts and dilates, it will be rubbing against the back of the iris, and it will cause pigment dispersion, uveitis, and you can have secondary glaucoma in these patients. So that's why 2.5 becomes very important. Okay, there are high chances of PCOS, because if you notice that the capsule bag is getting pulled anteriorly. So once it's pulling anteriorly, even if it gets fibrous, it's not going to push the lens back. When the lens is pushed backwards, IOL, it pushes onto the posterior capsule, thus reducing the chances of VO formation. But in this one, these patients, I think by and large 50 to 60% these patients will need a YAG later on. And when doing a YAG in these patients, you make sure that you do only central 3 to 3.5 millimeter opening, not a very big opening in these ones. And most of these problems will happen if you're too anterior on the scleral fixation. And if you are at the right place, 2.5, maybe a little 2.5 to 3 millimeter, you will never have these issues. Okay, now, what are iris hooks? Now, iris hooks are, I think, the biggest boon to the surgery in these patients. You can use it anywhere. You can use it on the iris, you can use it on the capsule, you can use it if you have maybe a vitreous coming from one side of the iris, you can just use it one place, you can use it on the entire capsule. So what is important here is you need to have a good rhexis. If you don't have a rhexis, again, because if you pull, it will run off. So rhexis is a must, use a good viscoelastic. And there's a concept of trampoline. Now what exactly is a trampoline? You must have seen this trampoline, the kids playing on that. So that's what your bag is like. That's what it is. So if you notice, there are hidden zonules here. So the lack of zonules, we can replace zonules. But the human eye is not that simple. No, you can't just go and put some zonules and attach it. You never know, maybe in the next century it will happen. So this is what you're doing. You try to strengthen the again. So you can put 2 hooks, 3 hooks, or 4 hooks. Hardness and luxation of the lens will decide how many hooks. Now I'm putting 2 hooks and just trying to show you. The trick here is that once you're putting the hooks, you have to make sure that you remove the parallax. You have to use the parallax. Now you see this hook is, you've seen one. The other angle, the other edge is not seen very clear. Whereas in this, both are seen. So this is because it's hitting the lid over there and it's rotating. And if it rotates more, it can actually cause a rupture and tear of the anterior capsule. So this is a bag which we never thought it was that luxated. Once we took out the cortex, we realized that this bag is total flaccid. Now you see how flaccid the bag is. And how do you check it? You put in the Helon or viscoelastic inside and you can see the entire bag. Now this is a 3 hook, and if you have more hard cataract, you can put 3, 4, 5, and harder, larger the hooks can make more stable. But at the end of the surgery, these hooks have to come out. You can't leave this hook intact as you can do in your trampoline. So once these hooks comes out, then you put in a CTR or a Sioni, and then you can suture them to the sclera. So few tricks about iris hooks is that the entry again has to be putting for the iris hooks has to be about 1.5 millimeter to 2 millimeters. Not at the place where you fix the bag, because if you come too anterior, every time you take in your probe, you'll be rubbing against the bag. It will be tenting anteriorly. Second trick, you should see, there are two things you have to see in these one. One, the shape of the angulation. If the angulation is U, which is a new iris hook, it works very well. So this is what looks like a U, and this looks like a U. And you see this V. V means that you used it too many times and it actually has lost its U. So it's opening up now. So U is becoming V, and the V is a sharp edge, and the sharp edge of the V can actually cut the capsule also. So you need U-shaped. Then you always check the pegs. The pegs are the rubber radars, rubber catches which are there at the back of the iris hooks. And if they are loose, there's no point in putting into the eye and realizing it too late that it's not working. So please check out your radars outside. I call them radars because with that you can actually rotate the iris hooks 360 inside the eye without any problems. But they should be functioning properly. So please check these small things before you go in. Okay. So insertion and removal has to be done properly. The complication with iris hooks could be so many. I mean, if you're not careful, you can tear the rhexis itself, because the tip of the thing can rotate and it can tear and it can go ahead. It can cause bleeding from the entry points. You're making entry points to the posteriors, and you don't use cautery there, and it can ooze in. The moment the cortex has been aspirated and you remove viscoelastic from the eye, there could be bleed coming in there. You can have descendant detachment. You can have irregular post-operative pupil because you break the sphincters with this iris hooks. You can. Now this is a patient in which a Sioni was put. You can see the knuckle of the Sioni here. This knuckle can be seen here, and there are a little VO formation and they're wrinkling on the anterior capsule. And this is a patient in which we didn't put any Sioni, and this is after 1 year both eye. Now this eye, if it goes worse, you can't do anything. Even if you do a YAG, it's not going to work because it's getting crumpled from all around. Whereas in this one, if you see, the lens is quite clear in the center, and it's 1 year, and we're following this patient up. And you still, if you notice, there's a VO formation which is happening under the knuckle, because that is the area where actually the posterior thrust of the lens is not pushing on the posterior capsule, and that is the area which is more prone for the cataract formation, and you can't avoid it actually. Okay, we did a little study in which we had this grossly subluxated patients in which we put a Sioni and a CTS, meaning we sutured on both the sides. So one side we put a Sioni, the other side we put a CTS. In this we did a sequential and simultaneous. Simultaneous, what we meant was on the same sitting we did both the sutures, whereas the sequential was, it was done in the gap of 4 weeks. Okay, so what we realized in this was group 1 in which both were done on the same time, and you can see there's a CTS here, and that's the Sioni and the CTS on the other side. Okay, and that's the other group in which also you can see, but one was done sequential and one was done simultaneous. We realized that the one which were done sequentially at the same time, simultaneously, had better centering. You see the UBM, the lens is parallel, whereas when it's done later on, even if your marking are the same, somehow it doesn't happen the same way. So in this one, if you see, it's little tilted, the other one is not. Okay. All right, so this is a case report in which a patient came with a subluxation, traumatic. So you have an iridodialysis with the lens subluxation, and we sutured it up using a technique in which we published that. This is called the stock and dock technique, in which we put the needle under the iris, and we put the needle, when I say, I mean a 20/60 needle, and it goes under the iris and it gives a platform for that, and the proline needle which comes on top of that through the iris onto the needle. Okay, if I don't have the support at the back, the proline needle can go anywhere and hit and cause damage. Now, in these patients, you don't have damage at all, and this was published in International Ophthalmology about 7 years back. Okay, so coming to the spherophakia, now I think that's the mother of all subluxations. The bag is big. No, sorry, the eye is big, the bag is small, so that's why it's called the microspherophakia. The pupillary block is the commonest presentation. These one, the lens comes anterior and does the pupillary block, and lens is mobile and keep coming to the anterior chamber. Now, this is what it looks like. How do you pick up microspherophakia? You can see 360-degree all around reflex of a corona. Corona is a reflex from the sun, is a ring, not, I'm talking about the coronavirus, and that's the same name though. And there is no differentiation of the cortex inside. You don't have a nuclear, don't have a cortex. They're usually clear. Most of the spherophakia lenses will be clear. So that's a trick. So since they're clear, they're refractively active. So these patients with -18, -20, with the thick glasses and still not able to manage well. So these are the one in which you need to do surgery. And this was the post of this patient. Okay, so this was the UVM done on day 1, and again repeated. You see the lens is in the anterior chamber and the lens has gone backwards. Okay, so I'll just show you this video. This surgery was performed actually at Westmead Hospital in Sydney. I did this surgery there, and this was about 7 years back. But this is what the recording they gave me from there. Now this is what the lens was. The other eye in this patient, they did scleral fixated lens because they could not manage to do a bag saving surgery in that one. So you make 2 entries on the side and the 3 entries. Now even I was not sure whether I'll be able to manage this one, so I was carrying my Helon 5 with me from here only. So I use Helon 5. Okay, I think I'll rush through. Okay, rexus is important. So if you see, the moment you put in the needle inside, you will feel the bag is lax, and the rexus is happening only because it's a higher molecular weight viscoelastic inside. Anything which has more than 5 million Dalton is good enough for this because it's like a viscoadaptive. It's holding, staying inside and pushing the lens down. So you have to reduce the anterior posterior diameter by pushing it with the Helon, because if it keeps coming anterior globular, your rexus is not going to happen. Go slow, tend to aim for a 4 millimeter rexus, you will always land up at 4.5 to 5. So if you aim for 5, you will go for 6.5, 7, it will go bigger. So don't do that. And every time you think the bag is getting, chamber is getting shallow, please put in viscoelastic and go again. Alright, so once the rexus is done, I think a majority of work is done. Now, once this is done, you have to do a gentle hydro in these patients. A bimanual is what I always suggest people to use for these lenses, because if you have a coaxial, the lots of fluid goes into the bag. With a bimanual, you can change the direction of the fluid. You can stay in the anterior chamber in front of the bag, and your aspiration can go into the bag. That way you can save the bag. Okay, slow, gentle. If you notice, I have not made a bag. I haven't making a capsular, the flap, scleral flap and the conjugal. See, the chamber is so shallow still. So putting in viscoelastic again and again to make it deeper. Now I've filled the bag with Helon, and I'm putting a moisture ring in this one. And those guys had moisture ring now. But this ring, if you see, it's already the big overlap there. So bag was so small. This moisture ring was about 12 millimeter. So it's already overlapping by say 3-4 millimeters. So this bag actually is about 8 millimeters, not more than that at any cost. And that's into the bag. And once that goes into the bag, and this is what the CTS looks like. That's a segment. That's a Ahmed segment, which I used for the first time there. But I realized that's a good segment to have because there's no ring here. So it's very easy to put in. You don't have to manipulate too much inside the eye. It just goes in without causing much of a problem. And if you have say about 3 to 4 Khokhar luxation, you don't have you don't want to put a CTR, you can just put one of these ones and it will stay stable forever. So since we didn't do the conjugal flap and the scleral flap earlier, we did it now only. And again, if you see, I'm putting the needle. Now, this suture I'm using here is a 10-0 protein. In Australia, they don't use 9-0. You were using 10-0 only, but now they switched over to 9-0 now. This is a 10-0 suture. That's why the needle which is used is not 26, it's 30 gauge needle. See, it was loose. You see, what I'm trying to tell you is, it was going in and I'm working at the alien place. So I was just trying to put in it coming out. So what you can do is, before going in, you can do a handshake outside. You can do this one outside in front of under the microscope. It'll be easier. So once one is gone, the second is gone, then you put in the segment and just pull the segment. You see, the segment is so much easy to maneuver, and it comes there. Again, I told you the knuckle has to come on the top. The knuckle comes on the top, and then once the knuckle is on the top of the capsule, you tighten it up, and the lens goes in, and then you put a pilocarpine. You see, there's an edge which is visible on the other side. So my plan was to put the lens of CTS on the other side also, but once the surgery got over, we realized the lens is properly centered, so we just left it there. And this patient has done 7 years back, is still following up with those people with a 6/9 vision, and they're very happy. Now see, the lens goes in. The trick which you have to do is, after everything has been done, you put pilocarpine. If you notice what, they've done 1, 2, 3 YAG. They tried all this guy was 8 years old. So they've done all these YAG PIs multiple to avoid the pupillary block which was happening in this patient. Eventually this is what it looks like, and of course then you suture up your the scleral flaps and the conjunctiva using the appropriate sutures, and that's what it looks like. Okay. So spherophakia can be done, but not in all the cases. Most of the spherophakia, this was published later on. So if the spherophakia cannot be fixed, so what you need to do is, this is a technique which has been published in London, done about 3-4 years back. We published this one. So what you need to go is, you go inside the bag, into the anterior chamber, go into the lens itself, and with the other hand also you just go into the lens itself. Once you have 2 openings, then you do a little gentle hydro there, and then taking a vitrectomy handpiece, you put it on the IA aspiration mode. We put in the aspiration mode, so it has an aspiration first and the cut comes later on. So cut comes at the end, so we actually don't press it all the way down. So once this has gone in, the other hand also goes in, and that has a cutter. It goes into the bag, and since it's already hydro has been done, it's already loose. So we just go there with a gentle aspiration to the tune of about 200 to 250, 300, and you can actually aspirate it gently. So I have aspirated the entire bag. There was no way I could have pushed this lens back because it was stuck onto the iris, and you'll see how strong the adherence was. If I'd left it for longer, it would have eaten up all the endothelial cells and given you a dystrophy, degeneration of the cornea, bad cornea, decompensated cornea. Alright, so slow, gentle, make sure you stay in the bag. If your infusion is inside the bag, aspiration in the bag, it works really well. And the lens bag did not move from its position because it's stuck onto the. Okay, so we wanted to send this for histopath. So what we did was, after this completed, I went into the forceps and removed this entire bag. And you can see now. Okay, no, sorry, I'll go back a bit. Okay, so I'll hold the bag and I'll pull it, and you see where I'm pulling the bag, you have the ooze coming from there. So it was all in the front, and that's the bag, entire bag. All right, so, and then you do a vitrectomy, and this is what is the phakic eye. Now you can do whatever you fancy. You can put an iris claw lens, you can put an AC lens, you can put a scleral fixated lens, or you can leave the patient aphakic or contact lenses if it's a unilateral case. So this is what it looks like at the end, and put a pilocarpine, analyze is good, it's looking neat, so that's fine. Okay, now what about the anterior chamber lenses? Anterior chamber lenses have gone out of favor, but if you're stuck in adults and you don't have any options, and if you know how the technique is done properly and the sizing right, you can actually go ahead with the AC lenses. They're not bad lenses. I have patients following with me for 25-30 years also. If you plan the AC lenses, you normally do AC lenses in the patient in which the surgery has gone wrong. So there's so many complications, bad with phacoemulsification, you try to put in a posterior chamber lens, it's dropped in and you've taken it out. So all those factors. The only problem with the AC lenses, which I feel, is that the sizing is the issue. They're only available in 2 sizes, and now we always put it under the air bubble. So I think me and Tushar have been doing this for a long time, and we put it under the air and the lens stays stable. Once that is there, you put 2, not 1 suture, please put 2 sutures, because if this lens comes and touches the back of the endothelium, it will eat it up, the cornea. So do a PI after that, and that's what it looks like at the end. Right. Do we have time? Okay. All right, so this is a patient which is followed for 20 years with me and got a PI, the lens is stable, the endothelial count is same as what it started with, it hasn't dropped much as compared to the other eye. Now, this was stability seen on a gonioscopy and a UBM. You see the lens is absolutely centered well. It's not causing any problems at all. You see little pigmentation there, nothing much. But the problem is they're available in 12.5 and 13 millimeter size. So if your white to white is less than 10 or more than 12.5, you're not supposed to put this lens in. So we did a thesis in which we realized that only the patient in which you pick up the size properly, if you do it in those ones, none of these patients had any problems. So the patient in which you have a scleral weakness, you can't put as SFIL on those ones. If the age is more than 6 years, you can easily go ahead with the Kelman multiplex lens, and your corneal diameter has to be right. If it's the bigger lenses, it can erode through the sclera. We've seen lots of patients coming out to us, maybe 4 to 5, not in our follow-up, but the patients run outside. And if it's a small lens, it will rotate and cause endothelial issues. Now this is what a knuckle comes out. I think all of you must have seen 1 or 2 patients of this kind. So you need to cut this off and push it back again. The best is to take it off and put a scleral fixated IOLs in these patients. But you should do it early before the endothelial decomposition sets in. Okay. Now, iris claw lenses were there ages back. They come back again, and now what we do is we put it in the back. Now, this is a patient which was a subluxated lens was done outside and sent to us for management of the phakia. So, in this one, I'll just show you what we did. So, once you dilate it, and this is what the lens looks like. Our artisan lens is the one. So, it has a convexity. So, the vault has to be anterior if you're putting on the iris, and if you're putting it behind the iris, the vault goes upside down. So, you put the lens upside down. So, it comes from a 5.5 millimeter incision. The lens goes in. It's a tight incision, but that's good because the lens goes in. Okay. All right. And you filled up the chamber with the helon here. So, this one goes in. You rotate the lens into the position, and you have made 2 incisions on the side here, which are not radial. Now, if you see this forceps, it has got a good firm grip on the lens. I hold the lens, I go behind, and I push it anterior from the back, on the iris. If you see there's an indentation. Yeah. Eye is too soft sometimes, so you put helon here now. Okay. There you go. You hold it. You can use this instrument to actually bring it in. Okay. So notice now, I go in, I push it anteriorly against this, and I can see the impression of the, see that? You can see the impression here? So that impression is there, and you know where the knuckle is, and you just go and ease it in. Okay. And that's it. Since it's been put from the posterior side of the iris, it holds very well. From the anterior, the chances of slipping is higher than the posterior. So once it's gone from the posterior, it holds very well. Okay, now similarly the other side we go holding it. Sorry. We have time. Okay, so I can show it. Okay, so again we go in knuckle, and you see I pushed it from here, and the other one is also gone. So it's quite well centered lens. And I try to tap it with this and see whether it's mobile or not. It's not, and PI is already done, otherwise I would have done a PI. The other trick, if you're putting the lens on the posterior surface and you put it upside down, you don't have to do PI in these patients because it's not going to cause pupillary block. Then you suture up the main incision because it's 5.5 millimeter, it has to be sutured properly. Put 2 or 3 sutures in the beginning, and then you see what fancies. Or you can make a scleral tunnel in these patients, and then you can avoid the suture. And this is what it looks like at the end. Okay. Now I don't think it'll be now. Iris claw lenses have the biggest history because in the pediatric age group, there's a study by Simena et al. In which they followed 13 patients for 14 years. That's the longest follow-up in the history for the iris claw lenses. And they realized that the endothelial loss was not seen much, and these lenses were put on the front of the iris. So if you put in the behind the iris, I think it'll be much better. So anterior fixation was done earlier. Now most of the people are switched over to the retro-iris fixation. Even if the eye is small, you can do this, and pupil may stay oval for in few cases. And sometimes there's a de-inclination, which is more often in the anterior ones, but not in the posterior. We're doing the posterior lenses for about now more than 8 months now, and we don't have any of the de-inclination happening in the posterior fixation till now. We're still following these patients. And the last video is of the scleral fixated lens. Now this patient actually came with aphakia. So basically, once subluxation lensectomy, vitrectomy has been done, you have to make sure that it's aphakic now. So after the scleral flap, conjunctiva has been removed from the area, conjunctival flap and the scleral flap, you put 2 marks. 2 marks to ensure that you're at absolutely 180 degree across. Then you go with the MVR on one side and then on the opposite side. Okay. Now, it's not the glue which works wonderful. This is the scleral tunnel which I'm making. This is the one which will hold the haptic inside. So this is more important. This is the most important step, I think, in the entire surgery. If you don't have this one, you'll have these haptics coming and eroding anteriorly, or they might erode posteriorly also into the vitreous cavity. So I put in a forceps from one side. Now here first I do a vitrectomy because there's some little vitreous which is still stuck. It was done earlier outside the surgery. So I removed that vitreous also. I'm making it totally aphakic so that my lens which goes in does not get stuck in any of these vitreous, fibrotic vitreous which was there. Then I open it up to 3.5. A 3-piece lens goes in after putting in Helon in this patient. A 3-piece lens goes in, and while I'm still in the inserter, I put in my forceps from the other side and hold the tip of the haptic and I pull it out. Alright, so that's one haptic. The second haptic similarly is held, pushed in, and one has to keep an eye on the haptic which has come out. So my assistant keeps an eye on that, and sometimes I ask him to hold it with the forceps, but now we have become more gentler and that's not happening. Otherwise, it can always go in. So once you hold it, always try to hold it the tip. This is I'm holding with the other side, and the other haptic has also come out now. Okay, now there's one haptic here, one haptic here. Can you see the blue haptic? Alright, so you have to presume that. So now I'm going to tuck these into the tunnel which I've created. I didn't use glue in this patient. This was non-affording patient. I mean, he could afford the lens but not the glue. So, alright, so that goes into the tunnel, and similarly the other one also goes into the tunnel. Yeah, and this patient didn't have a healthy iris also, so I couldn't do iris claw in this one. Maybe if there was an iris which was intact all around, I would have done iris claw posterior. So then you suture it up, and that's about it, and the lens is properly centered. And at the end, before you close the conjunctiva, you can always check again. You can always adjust with the haptic, the centration again can be checked. And once this is done, you're checking it up, and then you put the flap back and suture it up. And that's how it looks at the end of the surgery. Okay. Alright, so SFIL should be done if the sclera is healthy. I mean, I normally avoid in the pediatric age group because especially the subluxation, because of Marfan's or Abel syndrome, because sclera is thin in these patients. And this is one of the patient done somewhere else, and you can see the haptic come out in this patient. This was a 5-year-old kid. So I don't routinely suggest people do it in less than 6 years of age. Otherwise, you can do a swept source OCT in these patients. You can see the scleral thickness, and if the thickness is good, healthy, you can go ahead and do it. Otherwise, you should avoid in these patients. Okay. So now to sum up, most of these subluxations, actually you have to do a pre-op evaluation is most important thing. Tell the patient that it's not just one surgery which is going to take care of all the problems. You might just finish in one surgery, but from your side, you have to tell the patient that he might need re-surgeries and 2-3 surgeries in these patients, and might need a YAG later on. So if it's less than 4 o'clock hour, you can just do a capsule tension ring alone or a segment alone. Even that is wonderful. I suggest all these people, the beginners, if it's less than 4, maybe a 3-4. And if it's a congenital one, please put a CTS, not a CTR. For the traumatic patients, you can put a CTR, it will work well because the other zonules are healthy. For a progressive disease, CTS will work very well in these patients. Okay, from 4 to 9 o'clock, you can use anything between CTR and with the CTS or a SUNY. So when you're using this, which I showed you in the patient which I operated abroad, you use a CTR, a Morse's ring with a CTS, right? So CTS will suture it to the sclera, or SUNY, which has a knuckle itself. Or anything more than 9 clock hours, you do a lensectomy, vitrectomy, AC lens, SFIL, whatever I just showed you, whatever you fancy. And at the end, if you think you're not comfortable, please, if it's a bilateral case, you can leave them phakic, you can wear glasses and be happy. And unilateral, they can use contact lenses. And I think with that, I'll close this up. Thank you very much. Just stay safe and healthy, guys. We have 10 minutes for questions if you have any.
Live chat. On that. Live chat. Minimizing.
How do I minimize this? Escape.
Live chat.
कुछ है? अच्छा पूरे बंद करना इसको.
Live chat.
No, nothing.
Live chat. Chrome पे.
Chrome पे. Okay.
This is live chat.
Volume is low. Kindly put your doubts here. Any questions? Okay, Pooja Shah. That's the first one?
One before
One
that.
before what to do if there's difficulty in rotation of CTR?
Okay. So rotation of the CTR SUNY will happen only once your bag is not formed properly. Right? So you please go ahead and inject Helon again into the bag. If your bag becomes flaccid and it's collapsing, then CTR will not go in well. In fact, if it's wrinkled, it might tear through it. So what you need to do is form the bag. If your bag is properly formed, your CTR should not have any problem. Okay. Second one is, what is a great tip about what? Okay. What to do if there is a difficulty in rotation? What हो गया? Pooja Shah, was iris claw lens enclavated done with a bend? No, no. Okay, you can use a 30G needle also, but the tip has to be, you can just take rub off the tip. Otherwise, you can use Sinsky, but with these Indian lenses, if you use Sinsky, it opens too big. Sinsky has to be very fine Sinsky. You can use a 26 needle also in this one. Make sure that the tip is actually, you can dust it off with the sandpaper. Can we see the iris claw again? Sure, you can take a video from me, I'll give you. Don't worry. Suresh, Mahavir, I will power modification. Okay. No, I think that's a good question, Manish, because if you're putting the lens anterior and posterior, it will change. So there was a patient in which came to me for a secondary IOL, and surgery was on outside. Under the iris, there was a membrane which was left behind. I couldn't see it earlier. We did a UBM on the table, we realized there's a problem. So why I'm saying this is because you have to have both the lenses. You have to have the anterior and posterior lenses because both the lenses have different power. It's not that the lens which is anterior, you can put it back. No. So there's at least a difference of 1.5 to 2 diopters. So the posterior one is what we always ask both the powers now, and one is returned to the patient. Right? So there's a modification. You have to change it. Yes. So in that patient, I was trying anterior, but I couldn't do anterior, and luckily we had a posterior lens also. Sorry, we wanted to do posterior. We couldn't do posterior because of the membrane at the back. So when there's a membrane, we are coming from the back. The membrane comes first, then the iris comes. So I was not able to actually enclavate it. So in that one, I had to put anterior. So luckily we had a lens. So there are two different powers. Kindly show the second haptic enclavation of the iris claw. Okay. Okay, I'll show you again.
So is there any difference of iris hooks and capsular hooks during
Yeah, okay, I think that's a good question. I think capsular hooks are supposed to be used for the capsule, but whenever we use it for the capsule, especially in these spherophakia patients, the bags are small. So the tip of the capsular forceps will tear through the periphery, equator, in small bags. So it's best to use iris hooks for that. But use the one which are U-shaped, not a V. V means it's pointing downwards. U is coming backwards. So it will not be touching anterior or posterior capsule, where the V one will be definitely touching the posterior capsule, and when you're taking it out, it might just tear the anterior capsule also. Who's this BN? He wants to see the second haptic enclavation. Okay, so I'll show you again. Not now, but I'll send you the video anyway. Any other?
And sir, like during this retro enclavation, how do we actually control the pupil size? Because if it becomes too dilated, then also we cannot do retrofixation.
Okay, so when we started doing anterior captures, it's very easy because the pupil has to be the smallest possible, right? With the smallest possible, you can't do the posterior, because if it's too small, you'll be pushing the sphincter too much. So do not constrict for the posterior too much. I don't use Pylo for the posterior. I actually stroke the pupil on the round and leave it mid dilated. It works the best.
Don't use Adri also.
No, not in this patient, not in this one. But you have to have small pupil for the anterior fixation. For the posterior, please do not make the pupil too small. If the pupil is too small, you always get in trouble. Okay. SK great surgical tips. Okay. Thank you, Professor Titial. I hope the videos are clear. I don't know. I'm also rusted up. I haven't taken any classes for such a long. Show the second haptic. Okay, I'll give you the video of the second haptic. I'll give the entire video actually. Sorry? Ayushi. Is the bag supposed to be cut completely before putting in an iris claw? Yeah, if you're doing a posterior iris claw, Ayushi, it makes sense. If you're doing the surgery there on the table, a fresh capsule rhexis might not bother in capturing. I think it's a must to remove it. I think it should be removed because if it gets fibrosed later on, the grip might not be very good. So anything under the iris, if it's there, it will not let you catch it from the back. And if you don't catch it well and you're holding to the membrane, not to the capsule, not to the iris, then it might again become loose and fall back again. So I think it's a good idea to remove the entire bag in this one if possible. Yeah. Thank you, Professor Titial. Classic, your videos, yeah. Mine are not that classic. It's just because most of the people get stuck with the subluxated. I thought I'll talk on this one, and next time I'll talk on the pediatric cataract. I think that everybody knows and doing pretty good. But subluxation I picked up because I thought this was good, and there was little small techniques, small tricks which people should learn. And it's not difficult to manage it because we're doing it for donkey's years now, and if you do it well, and you can get away with that. Okay, yeah. What would be the role of femto in subluxated lenses? I think Dr. Titial has done lots of cases on that one. Yes, you can do anterior rhexis, you can do very well with this one, but again you have to use iris hooks and CTRs and Sionis where are required, so you can't get away with that. Yes, the capsule rhexis will become better, but maybe if the vitreous is coming in the front and it doesn't cut properly the full rhexis all around, you might get into trouble also if the vitreous is in the front. Do you get my point, Navajas? Because if the lens is already rotated, tilted, then the energy might not go equal on around the entire rhexis, and you might have an area which is not cut. But yes, Dr. Titial has worked and says flax works well, so I believe him. Yeah, I haven't done too many on the flax. I did 2 patients recently on the machine which has come downstairs in the OT, because because these are small kids under GA, and they worked pretty well actually. Priyanka, sir, can we use a 3-piece in the back? Of course. Of course. You can use 3-piece also, but because 3-piece haptic has a memory. If it's a small one, yes, you can do it. Go ahead and do it, and make sure that it aligns up with the subluxated area. You can get away with that. But still, I think if you want a proper centering over a longer period, a CTR which comes for 450 rupees, I think you should go and put it. CTR should always be there with everybody. So whenever there's a doubt in mind, the video which I showed of CTR, I could have got away with the lens 3-piece also, but putting a CTR makes sense because that actually distributes the energy, the strength from all the other zonules, 360 degrees. Whereas if you're putting the lens, it will be just on 2 directions only. So it might not work very well. Patil, thank you very much. Okay, no, that's okay. Lensar, I just forgot the name. Nitish, is there any other suture which can be used instead of Prolene as far as the strength? Okay. So in USA, people are using Gore-Tex. They're not using this suture. They're using Gore-Tex for this for all the fixations to the sclera. I don't have any experience with Gore-Tex. We're just writing up a book, and I asked one of the Americans to send a video. So Gore-Tex is what they use, and it's flexible, and it is managing. They're very happy with that. I haven't had any experience with the Gore-Tex, please. But yeah, Gore-Tex can be used. Yeah. We got 3 minutes more. That's it.
So like in congenital field subluxation, where like initially we have suppose 4 clock hour subluxation, and intraoperatively it increases to like in those cases.
Yeah, see what is happening now is that all these pediatric subluxations, especially with the Scleral lenses, and it's a progressive disease. We don't fix them now. We eat up this. So I showed you the interlenticular procedure. So that you can do with the lens behind the iris also. One stab in, one other stab in, go all the way. I had the videos, but it would have just not. I wanted to give some theory also background, because otherwise it wouldn't have been a lecture. It would have been one way. So I think that way. Yeah, but so in that one you eat it up and do a retrofixations, and that's what we've given a thesis topic to this new girl just joined in. So let's see how it works. We've done about 15-20 patients over 6 months now, and they're doing pretty good. Okay, now what is this? What if there is some capsular tear present? Okay. See, if the capsular tear is there, before you put in a CTR, you can just hold the edge of the tear and make it a round rhexis, make it a rhexis. So that way it becomes contiguous. Or I think you should avoid putting, because in the beginning, if you overfill the bag again, it will cause the stretch on the tear, and it can extend, and it can cause trouble. So you have to be careful about that. If it's a small nick, I suggest if you picked up the nick well, just hold the tip of the nick and just pull it in. You just snap it inwards towards the center, and it will just become a round. It will become contiguous. It will not stay round, but it will be contiguous. I think that will work well. Manisha Mansi, so how often are the iris claw associated with complication due to chronic irritation? Okay, so anterior ones had more problem because the lens was in the anterior and sitting on almost on the iris. But the posterior ones are just holding the iris at the back in 2 claws, and it's actually having a vaulting posteriorly. So it should not have technically more at the back. Any specific indication for anterior vitrectomy in management of the subluxated lenses? Yeah, I think you should always do an anterior vitrectomy in these patients, because once the lens is gone, there could be the fibrosed anterior capsule, the anterior hyaloid, which might not let you do a proper iris claw fixation or a SFIOL patient. So in those scenarios, it's better to do some vitrectomy before. It helps you. I think it should be done. So what can be done in case of anterior capsular extension? Okay, if you have an anterior capsular extension and you're really daring, you can put a CTS segment in that area and gently tighten it off the records. I've done it in one patient, it works well, but don't try that if you don't have a good viscoelastic and if the block is not good. You have to have a very soft eye and you can do it. What lens technique do you prefer in Marfan's? Marfan's, okay. So Marfan's, if the luxation is more in most of this patient, I go for intralenticular aspiration, which I showed the technique, which I was doing in the anterior, can be done in the posterior also. And then in most of these patients, Marfan, I don't do anything with the sclera because sclera is again thin in these patients. So if the sizing is good, you can go anterior chamber ACIOL. But now we started doing iris claw in most of these patients, and I think let's wait and watch how they're coming out, because the literature says the iris claw lenses have the best track record in pediatric age group as of now. Okay, so will you please highlight regarding the vault while putting the anterior and posterior? Okay, when you're putting anterior, it's like a ICL. The vault is anterior, so that means the concave surface, convex surface is toward the cornea, and when you're going downwards, it's the other way around. So you're going away from the iris either way, anterior and posterior both. In the anterior, it's coming more to the cornea. On the posterior, it's going more towards the vitreous. Is that clear? Suman, okay. Yeah, I know Dr. Bhagwat, I know you well. You're here with us and you're doing very good in AIMS Bhubaneswar now, and I wish you all the best. Sometimes the capsular hook slips again and again. Capsular hooks. Yeah. Okay, now, it slips only when your lids come into the scene. The ones which are on the nasal and temporal side will never slip. So please do not put one at 9 and 12 and 6 o'clock. Avoid putting hooks at the 12 and 6 o'clock. If you can go in between, then it will not slip. It slips because the lids will hit the thing, and otherwise sometimes after putting, and if the stick which is coming out of the iris hook is longer, you can trim it off a little bit so it doesn't hit the speculum or the lid. Yes, Professor Titial, you can use a laptop here, no problem. Otherwise, but the system works well. I use their system, yes, but you can use a laptop here. Dr. Pradeep Sharma used a laptop day before, so it shouldn't be a problem. If that's it, I think we'll conclude it. And any other questions, also you have my emails. You can feel free to ask me, and you can catch me anytime in my hospital office. So no problem. Is there a PCR after insertion of? Good one. And phacoemulsification at the time. If there's a PCR after the insertion of CTR and phacoemulsification. Okay, if your CTR has already gone in and there's a rent which has happened, you can just go with a vitrectomy probe right through that and remove some vitreous from there so the thrust is not there, and then you can put a 3-piece lens in the sulcus and you can capture with the opening. And try not to rotate the CTR in these one, and it will work well. We've done it in the past, it works well. Okay, sorry, there's a PCR again, and how to prevent, who's this? The question puts right. How to prevent capsule tear while doing phaco in subluxated while using hooks? Again, make sure that your hooks are good, and the position of the hooks is important. Don't bring it too anterior. And if you have more subluxation, please use more hooks. That way, you can hold the bag better during the phacoemulsification. So I think for the beginning, the cassette which comes gives you 5 hooks. Please use all 5 in the beginning, and once you get used to that one, you can reduce the number of hooks. But for the beginners, I suggest you put all 5 hooks all around and do the phaco as if it's nothing has happened in the eye, and you will not have any problem. And make sure the chamber is formed, the incisions are not too big, and phaco handpiece you're using should be snugly fitting so that you don't have too much turbulence. How to prevent? Okay. Navneet Sidhu. So in case when we put CTR before phaco, it should be put before or after hydro. I think it's always a good idea of putting it after hydro so that you have a space in the periphery, some fluid goes in, and the cortex gets detached from the periphery. I think it's always a good idea to put it after CTR, after the hydro, please. Raghav, oh, too nice. Thank you for the, oh yeah, great. Wonderful lecture. Dipali, so what are the indications of CTR and Sioni combined with CTS? Okay, if it's 9 o'clock hour, I have a Sioni, I'll go ahead and put a Sioni. If I don't have a Sioni, I would put a CTR and put a CT segment. And if it's more than that, I don't put a CONE with 2 knuckles. 2 knuckles means there are too many sutures there. Too many sutures there. So I put CONE on one side and CTS on the other side. So if the too big a luxation, I am able to manage a rhexis. Then in those cases, I'll put iris hooks all around, 5, 6, do a phaco, do aspiration, and then put a CTR on one side and a CTS on the other side. Sorry, a CONE on one side and CTS on the other, and I'll put 2 sutures then on the sclera. Okay, Deepali, hope you're fine. Deepali, make sure you're healthy, stay good, and I think that's the end of it. Thank you very much, guys, and bye, and stay safe. No, thank you. मैं थोड़ा rusted हो गया हूँ मैं. I haven't been taking lectures for. I've been watching.